today, but then Sonali mentioned what she was teaching in this morning's session to the master's students was around the role of the environment, nature-nurture debates, and also attachment theory. And so I thought a piece of work that I've been doing for a number of years, where we're looking at working with health visitors to support health visitors, to support families, to provide responsive contingent interaction in the home might be something of relevance to the learning that you had this morning. So I thought I would talk to you about that today. And I particularly wanted to draw through the fact that when developing interventions, this process is an interaction. The way that I develop interventions anyway is created through a synthesis of theory, best available evidence, and parent and practitioner views. So this is going to work. No, it's not. I'll use it with that. So I'm an empiricist, so I absolutely believe that in the practice pyramid of evidence, that randomized controlled trials and meta-analyses and systematic reviews are the most highest quality of intervention evidence. However, I also align with the guidance of the Medical Research Council for the development of complex interventions, that you can't, if you jump straight into evaluation, then you're going to get things very badly wrong. And you need to do very principled development and feasibility and piloting work if you're going to have a chance for your intervention to actually have an effect. And also if you're going to have a chance for this intervention to really work in the real world and not simply be a good idea that somebody has. Susan Mitchie talks very often about in the past the approach to intervention development was what she called Isla Jayat, which is, it seemed like a good idea at the time, was mostly how people started to develop interventions, whereas in the past 20-25 years we've developed much more principled approaches to how we use theory to underpin our intervention development. So this is what I'm going to talk through today. Then I'm going to give you a little bit of background around early language and individual differences, because that context is important in terms of how and why we've developed the intervention in the way that we have. Then I'm going to talk about why would we bother to design a health visitor intervention for early language? Why does that seem like a good idea? And then I'm going to talk to you about this particular measure and intervention that we've developed. So it's the Early Language Identification Measure and Intervention Study, the ELIM-I. And I'll talk you through how the intervention was designed, some key findings from our research, and then talk you through and show you the intervention itself. I have far too much to say, so please wave at me if I go on for the rest of the afternoon. I'll try to not do that. Okay, so talking about early language and individual differences then. So as for all other aspects of child's health and development, children's language development is in fact affected by numerous factors. So good old Bronfrey Burner is relevant to children's language development as it is to all other aspects of children's health and development. And so the child's language is development is influenced by factors intrinsic to them as individuals, but also their immediate family environment and educational environment, which are then obviously affected by policy and practice environments around the edges of that. And so despite some very deterministic early theories about what child language development looked like, there's actually really widely varying individual differences in children's language development, both in terms of their relative abilities in comparison to their peers, but also in respect to the trajectories, the patterns of change over time that children's language takes. And so, as I say, there's hugely varying individual differences in children, and these can be in part explained by the environment that the children grow up in. So due to the influence of these environmental factors on children's language development, what we find is that children's language abilities follow a social gradient. And so there are inequalities in children's language that are linked to the socio-economic circumstances of the child. So this gradient here is, it's not like a sharp cliff edge whereby all children are doing fantastically well and it's only children in poverty who have the lowest language abilities. It actually correlates with socioeconomic circumstances. So with each decrement in a child's indices of deprivation, the lower the average language ability of children across the population. And we're showing this here in the UK in the Millennium Cohort Study, Growing Up in Scotland study. This is in Melbourne, Australia. This is a link to social disadvantage. Then again, we're looking at Millennium Cohort, but this is with parental education, and then in Denmark and Germany as well. So this is an internationally present pattern that we see. So on average, 1 in 10 children have persisting language difficulties, which affects their social relationships and their learning. And in the UK, that sort of is equivalent to about 3 children in every classroom have a language difficulty that's going to affect their daily lives. However, because of that social gradient that we were talking about, in socially disadvantaged classrooms, that can rise to approximately 40% of children within a classroom having these difficulties with significant consequences for them. But in addition to there being a social gradient in children's language abilities, there's also inequalities in access to support and help. So only fewer than 50% of children who have identified needs actually seek or receive support for additional learning needs. And these additional supports are also harder to access for socially disadvantaged families. So it's not at random. There are, you're less likely to receive support if you live in a socially disadvantaged area or have a less well-educated parent. You're also less likely to receive support if you're female than if you're male as well. So there's lots of inequalities embedded within the system. Just so that we understand the importance of this, for children who have persisting difficulties, the consequences can be really profound and the risks can extend well into adulthood. And the risks that we've identified in the literature relate to children's having poorer mental health outcomes, poorer quality of life and well-being, poorer educational outcomes, less likely to be in employment, poorer literacy outcomes, experiences of social exclusion, and really high levels of experience of the youth justice systems. So there are really, as I say, profound consequences that extend across the life course for children who have persisting language difficulties. So that's just setting some context. I think so. The next point that I wanted to talk about is why did we decide that we wanted to design a health visitor intervention for early language? So maybe I should say who health visitors are for people who maybe aren't from the UK. So in England, there's a public health programme that's delivered to all children called the Healthy Child Programme. And it's delivered universally to all families by a range of public health services. But from birth to 5 years, this Healthy Child Programme is called the Best Start in Life. And this is delivered by health visiting teams. So health visitors are trained nurses, so they've trained in the hospital as medical nurses, and then they specialise in health visiting. And they have teams which also include early years practitioners who may be trained in an educational context and then work in partnership with health visitors. So they provide families with a programme of screening, immunisation and health and development reviews. And the idea is that they're universal reach. So every single child has a health visitor assigned to them in the UK. So they have universal coverage. And then they have a personalised response. So the idea is they meet the families where they are and they modify what they provide families depending on what the family needs from them. So in addition to these programmes of screening and immunisation and reviews, they're also supplemented by additional advice around health, well-being and parenting. So can I ask for non-UK people, is there an equivalent of a health visitor in your context? No? Okay, that's really interesting. So sometimes they're called family nurse partnerships, or sometimes they're nurses who are linked to a paediatric office, potentially. No? Okay, yeah.
And I was gonna say, in my home state of Oregon, there are small scale pilot programs of nurse family home visiting programs, but they don't receive a lot of funding and don't have much coverage throughout the state.
So it's a bit like early years education, where the evidence is massive that it's a really, really good idea, but governments don't want to invest in it. So I'll say health visiting is a similar scope that has massive positive benefits, but it costs a lot of money, so people don't want to invest in it. Annoyingly, but we do have universal provision in England, which is really fantastic, in the UK actually. So why would we design a health visitor intervention for early language? So we all know that the earlier the better. So early interventions bring greater gains than later interventions through the action of positive developmental cascades. And as I've said just a moment ago, health visitors are unique in their universal reach in very young children. There's no other professional group in the UK that meets every single family or has a mandate to meet every single family in these years. So they're in an amazing position. They're also really highly skilled workforce. So it seems like a great idea, but they also have very limited time and huge multiple responsibilities. And during COVID in particularly, one of their biggest responsibilities is around safeguarding, so ensuring children are not being neglected or abused. And that responsibility took over a huge amount of their time during the COVID period. They're not specialists in language interventions, so although they are very highly skilled, this isn't an area that they're trained in. It's part of their mandated training. And also, there was a skepticism for a while about whether or not language was a priority or a good fit for somebody who, a workforce that's interested in public health. So is child language really a public health issue? Well, the short answer is I think yes. But anyway, I'll tell you now why I believe it is. So for an issue to be considered a public to require a public health response, there's certain criteria that have to be met. It must place a large burden on society. I think I've just demonstrated that it's highly prevalent. So you've got 10% of children who've got difficulties, and if you do have these persisting difficulties, they're going to create a huge burden for that individual across their lifespan and on society if individuals are entering the youth justice system, not entering employment, etc., etc. So I think we can give a tick that it definitely places a large burden on society. The burden must be distributed unfairly to require a public health response. And I think, given the social gradient that we demonstrated in the lack of access to services that we talked about, we can definitely say there's an unfair distribution in children's language difficulties. And there must also be evidence that early preventative strategies can substantially reduce the burden of the condition. So this probably is the weakest criteria of all of them in terms of the evidence that we have available to us to say that language is a public health problem. But systematic and thematic reviews demonstrate that there is some good evidence that it's possible to improve children's language skills through early interventions that are aimed at either whole populations or at some targeted groups who are particularly at risk. And that intervention, evidence is usually about working through parents or working through early childhood educators. However, the evidence could definitely be better in terms of design, so it's not always the most robust designed evidence, and also in terms of fit to resources. There's still a lot of work to do to make this evidence that's out there possible to be delivered within public services as they currently are configured. And so I would say there's a tick, maybe we should have a little question mark next to it, but there's definitely a tick. I would say that there are early preventative strategies that could substantially reduce the burden of the condition. And so in response to that recognition, it was interesting, Public Health England in 2019 decided to put early language and communication within the remit of health visitors for the first time, and to see it as a public health issue. And they decided, they call this the best start in speech, language and communication, and they wanted to commission some work to create a national approach to the support and development of children's early language. There was a number of components to this work, including sort of training of the whole health visitors workforce, but there was a specific piece of work that they wanted done, which was to look at a point in children's development. So health visitors have to see children at certain points in their development, and they have to see every child between the ages of 2 and 2.5 years to look at how their development is progressing. And Public Health England, our public health body at the time, wanted to develop something for health visitors to use at that review to measure and identify which children might have difficulties and offer some intervention. And also they wanted to understand parent perspectives about that review and how comfortable they felt talking about children's language development at that point in their children's developmental progress. And so they commissioned this work, and I worked with James Law, Caitlin Holmes and Sue Alston, and I led the intervention development package to respond to this call by Public Health England, as I say, in 2019. Interestingly, when Public Health England started the work, well, I think it's interesting, they just wanted to develop a measure. And in our conversations with them, we said it's utterly unethical to develop a measure if you then don't have a response. You can't just go into the family home and say, oops, your child's got a problem, see you in a year. You do have to be able to do something about that. So the intervention was through some sort of bullying and lobbying that we got that into the bid. So the aim of, so I'm going to talk to you about the intervention then, and the aim of the intervention was to design an acceptable, feasible and equitable early language intervention. So something that's acceptable to families and practitioners, feasible to do in the busy visits that health visitors have, where they're looking at everything else, and equitable, so that we're looking at making sure all children benefit as much as we possibly can. And doing that by synthesising current best evidence with stakeholder views. So the idea isn't to replace speech and language therapists and what they can do, but rather to supplement it and have a rapid response if a child's identified as requiring additional support. Waiting lists for speech and language therapy in the UK are terrifying, and so actually having something that the health visitor can do while the children are waiting for SLT is what we were trying to do at this stage. Okay, so now I'm going to talk to you about the early language identification measure and intervention study, and how we went about designing the intervention. Okay, so it was completed in close partnership with stakeholders across 5 sites in the UK. These sites were identified by Public Health England as being very diverse in terms of their geography and demographics, and also but having very high levels of social disadvantage in all of the areas. We use methods which maximise stakeholder co-design and involvement, and below you'll see the methodologies, the references to the methods that we're using as I go through. We completed 13 workshops, co-design workshops, and we used the latest guidance on intervention and development, which again you can see here about methodologies to create robust interventions. We drew on a range of implementation science theory, which I'll explain a little bit more in a moment about what that means. So implementation science theory is really about how you make people change their behaviours, how you make that stick, how you make it sustainable. So how do you actually make the intervention work in the real world? And then obviously being informed by child language development theory and evidence as well. At this stage of the research, we worked with 28 health visitors, 8 speech and language therapists, and 7 parents and caregivers. We were all set to go and work with another 12 parents, and the day before I had my train booked, and then we went into COVID lockdown the day before I was supposed to get on my train. So this is a COVID affected study. However, for each of these participants, we met them multiple times. This was an iterative process, so we spoke to them on many occasions, and we've done some more work subsequently in the North East as well. So the development processing involved 5 stages with different activity at each stage, and different outputs were produced by the different pieces of activity, which then fed through to the next stage. So stage 1 was an evidence review, drawing on recent systematic reviews, and here we identified the effective interventions for children in this age group. And the output from this was a logic model of what we thought the intervention should look like, and specific key papers that we were going to draw on to inform the intervention design. Stage 2 involved extracting the data from those papers and designing co-design workshops to run with stakeholders. So the outputs in this phase were identifying which intervention behaviours we might target. What does the intervention tell us we should be trying to change in families? What are the intervention techniques that seem to work? And also, and as I say, and then we developed the workshop materials. One thing we did in these co-design workshops is we created things called persona. So this is actually stolen from IT co-design. So people who design apps use persona in their app development. And what you do is you create descriptions of people with different demographic characteristics. And then within the workshops, you say, well, how would Mary deal with this? How would James? How would Iram? How would these people cope with the intervention? So you use these persona, as I said. So yeah, and then oops. So then we ran the co-design workshops, and in these workshops we looked at the barriers and enablers within families and services to actually being able to deliver these interventions, how acceptable they were, and what kinds of characteristics would work for different families. Once we had that information, we then did some theory consultation. So we took the information from the co-design workshops and considered further theory. I'm being distracted. It's not good, is it? Focus, Cristina. So we mapped what we were finding from these co-design workshops to the COM-B model and the theoretical domains framework, which I'll talk to you about a little bit in a moment. And then we created a prototype, a paper prototype of what we thought an intervention pathway and materials would look like. And then stage 5 was co-design workshops again, where we went back to people and they ripped it apart. They said, oh, that's terrible, that's a good idea. Oh, we love that, don't do that, what are you possibly thinking? And we did that iteratively numerous times until we came up with a intervention model and recommendation. So, as in the title, what I wanted to do was just call out a little bit more how we use theory and evidence in this intervention design. So we obviously used child development theory and evidence first of all. So we looked at current understanding of how children learn language, and this is obviously rooted in social, cultural, and social interactions theories. So I feel like I'm being watched. So Professor Bruner, Vygotsky are the key theorists who we were drawing on in our work here. So, and the theory obviously says that language is learned through interaction, and that language is easier for children to learn when it occurs in interactions with certain qualities or characteristics. And these optimal qualities change as a child develops over time. Rowan Snow produced a beautiful paper in 2020, one of my favourites. If you're interested in responsive interaction, have a read of that. And they've done an empirical, it's a very empirically based paper where they've drawn together what's the evidence that if you do this as an adult around a child, that it changes the degree to which you learn language. And they talk about these optimal qualities being responsive contingent interactions. Now, I have a little video here of let's see if this works. So this is a spoiler. This actually comes from the intervention in the end, which is about how to be a super communicator. But there's a little video here of a father doing absolutely fabulous responsive contingent interaction. Just get it to the right place. It's not going to let me jump. We're going to have to watch. Oh, I'm sorry. We're not going to do the music. Let me. That's a teeny tiny moment, but within that teeny tiny moment, that father has watched where the child's focus of attention is, heard her say the word stocks, has added some additional information onto that utterance and expanded on that, produced opportunities for repetition, and provided a number of models for that child in that tiny, tiny moment of interaction. And what Rowan Snow show is that the frequency with which children engage in those responsive contingent interaction opportunities is more important than just the amount of language that they hear around them. So it's these qualities of interaction that really make a difference for children's outcomes. So a responsive adult then is not directive of the child's attention, but follows their lead, watches and listens carefully for communication, respond to the child's communicative attempts with language relating to that child's focus of attention. And they're also responsive to the child's level of development. So the language that they use is within the child's zone of proximal development, taking them to the next step in their language learning journey. So this was central to our intervention design. Systematic reviews and meta-analyses demonstrate that interventions that focus on responsive contingent interaction in daily care and play routines and also within shared book reading contexts are effective, and the meta-analyses estimate effect sizes of moderate to large for both of these approaches. So there's evidence that interventions work if you can harness these behaviours. So as I say, this is what we took through from that evidence to our intervention design. We took through that these are core behaviours to be focusing upon in our interventions. The other aspect of child language development theory and evidence which we took through to our design is that it's harder to provide responsive interaction if you're living in poverty or living with other challenges. The good old Bronfenbrenner again, ecological systems theory. So those damaging generalisations are made about socially disadvantaged families, both in terms of the nature of the early environments and the reasons for any difficulties that they have in providing responsive interaction. It's clearly harder to provide a responsive environment if you're living in poverty or if you have numerous difficult circumstances. So if universal approaches don't address these inequalities, they can widen rather than narrow inequalities. And so we drew on the work of Marmot, his idea of proportionate universalism, to address health inequalities in our intervention design, so that the intensity and scale of the service delivery is tailored to the individual disadvantage and need. So this is for equitable outcomes, a proportionate approach will be necessary, but how can we deliver this in health visitor visit? We also drew on our knowledge of early child language trajectories. In the early years, language trajectories are really volatile. So low language at 2 years is indicative of a child who's going to have language problems, but it's not definitive. So many children recover, as it were, from having low language at 2. But also when you use population studies, there are also children who look like they're doing fine at 2 who are having problems later on. And so therefore, in our interventionary design, we needed to make sure, that for universal prevention, we believe that all families should be helped to support their child's language development, whilst also finding ways to not create undue anxiety. So that was one of our challenges. How do we do this? We drew on the COM-B model. I don't know if you know about the COM-B model. Many of you do. There's some nodding going on. So this is a really important implementation science theory framework. And in the COM-B model by McKean and colleagues, they suggest that if you're going to change a behaviour, whether that's going to the gym more often or using responsive contingent interaction, then we need to consider these different potential barriers or enablers. So a person's capability is their skills and knowledge in that given behaviour and skill. Motivation is obviously motivation, but it's also more broadly aspects like your emotional response and your affect and your attitude to this behaviour. And opportunity are obviously the physical and social opportunities to doing those things. So you need to have many of all these enablers in place if you're going to change that behaviour. And we also drew on something called the theoretical domain framework, which allows you to map these aspects to intervention techniques. It's a really beautiful piece of work by McKean and colleagues, which allow you to say, okay, if I've got a barrier in this capability area, what kind of intervention technique would allow me to change that behaviour? So in our co-design workshop, we examined barriers and enablers to using the intervention techniques found in the evidence, using the COM-B model. We matched them to the TDF to look for the relevant intervention techniques that we would use, for example, like reflection, accessing social support, goal setting, etc. And that fed through into our intervention design. We also, I'm not going to go on about this too much because we found this didn't work really. So we used FECON's theoretical framework of acceptability, which details what makes an intervention acceptable, and they pull through all of the different aspects which might make an intervention more or less acceptable to a family or a person. So it's things like the burden, for example, of how much effort does it require might be part of the whether or not something's acceptable. Intervention coherence, so this might be how much does it align with your value system as an individual, for example. I'll tell you later why we didn't find that particularly helpful, but we did use it. And so in our co-design workshops, we examine the acceptability of these interventions according to those constructs. Okay, so what did we find in this first stage then? So in terms of acceptability, we found that health visitors were really committed to offering language intervention at the 2 to 2.5-year-old review, but they were nervous. They weren't sure how to do it. They wanted to do it. They were sold that it was a public health issue, but they were really unsure that they had the skills. Parents and caregivers really wanted to be proactive, and they wanted to be given agency in supporting their own children and to do it as soon as possible. So they were really keen to have something at this stage and for them to take responsibility, be the actors in this space. So we also found that when we talked to them about responsive contingent interaction, this was a highly acceptable approach for families and health visitors. They all thought, yes, this makes sense. This is something we want to learn about, something we want to do more of. But it was important that this needed to be within their daily routines. It wasn't an additional thing that they had to do in their daily lives. It had to be something that's threaded through their daily routines. In terms of equity, we found not only did the intervention need to be proportionate, so as I was talking about this idea that Marmot has a proportionate universalism, Marmot suggests that you need to have higher intensity of intervention for people with higher levels of disadvantage to enable them to make change. And we found, yes, that was the case, but also it wasn't just the amount that needed to differ between families. It needed to be tailored considering the specific barriers and enablers and assets and challenges that were in place for each individual family. Then this was something we weren't looking for in the our intervention design, but it came through so strongly. There were numerous factors that could either make or break an intervention with a health visitor. And the importance and the potential fragility of an alliance and partnership between a parent, caregiver and a practitioner was really hard to overstate. Health visitors can ruin it within the first 35 seconds of walking through the door, the first minute, the first 2 minutes. Parents can feel that they're no longer engaged and they no longer trust this practitioner if you just get it wrong. And so it was vital that the following issues needed to be taken into account. So obviously ensuring families don't feel blamed for their child's difficulties. The use of the nature of the language and communication that the practitioners used when they spoke to family was absolutely key. And as I say, they could get it wrong very easily. Shared decision making was vital, so the parent needed to feel that their voice was on equal footing with the practitioner and that they had agency and self-efficacy in the decisions that were made about them and their families. It needed to be tailored, and this wasn't just so it fitted in with the family, but also so that the family felt that they were respected and that the things that they were already doing were being valued and honoured. Shared book reading was the most divisive technique approach that we talked about in these co-design workshops. Not because it was terrible for everybody, but that every family was in a very different position about shared book reading. And if you didn't take that personal individual family's circumstances into account, you could alienate that family very quickly. So this was a family who felt patronised. If somebody said, "Are you reading books to your child?" wanted to slap the health visitor, was how she put it, to a family where they said, "Oh, if you think I haven't tried sharing a book, he doesn't want to, it's incredibly difficult." Or my literacy skills are such that I find that terrifying to go anywhere near books with my child. So it was really interesting that not only was this, like I say, about getting it right, but you can really alienate a family if you don't tailor. Trust and equal partnership between the parent and the carer and the practitioners is vital. And almost, this is why I was talking about the acceptability thing not being particularly useful, almost any intervention technique that was in the literature is completely acceptable as long as the family felt that they had trust and alliance with the practitioner and they felt listened to and supported. I'm looking at the time, so I started, probably got about 12 minutes, 10 minutes.
Yeah, you can take 20.
I can take 20. Oh, thank you. Should we all move about then? If that's the case. So after we'd got to that stage where we'd understood everything about, we'd understood the intervention, what happened was we created a framework and a set of guidance for health visitors about what an intervention might look like at the 2 to 2.5 year review based on that. At this stage, in 2020, Public Health England published this guidance and a handbook for the use of the ELIM-I and delivered national training through a cascade model. But we felt really strongly that practitioners needed more than that to be able to actually deliver this in practice. And so we got some further funding from the EEF and from my university at the time, supported this work, and we secured a partnership with BBC Time and Happy People as well. So one of the core intervention techniques, which is the most powerful techniques and which came through as being really valued by parents, was modelling. So seeing somebody else modelling what we mean by responsive contingent interaction. And obviously, health visitors can't be in every home modelling these approaches for everybody. And so we spoke to BBC Tiny Happy People to see if we could develop a suite of video resources which would enable these to be modelled. I think they're beautiful, but you can tell me when you've had a video at their website. So then we did some more co-design. I've lost track of how many iterative cycles we've done with various people where we kept trying things out and developing resources. And we did that with a further 16 health visiting team members and a further 8 parents and caregivers in the northeast of England. And then we've drawn yet more theory and evidence. So because of what the parents and caregivers had told us was so important, we went back to the evidence around how do you establish and maintain a therapeutic alliance between a practitioner and a parent? How do you embed shared decision making, the creation of agency, autonomy and self-efficacy between a practitioner and a parent? How do you tackle those power imbalances between a practitioner and a parent and create strengths-based approaches which value what families are already doing? How do you create models of coaching which are possible for a practitioner to do in a single visit with a family? And how do you use normalization process theory, let's say, to ensure that the teams of people who are trying to implement this approach are able to do it, able to implement it, able to make it part of their everyday practice? So we went back to the theory for those aspects which we felt we hadn't considered sufficiently. And what they fed through into the final model is they gave us some guidance on the specific language that you would use to talk to a parent and the intervention processes which you can embed in practice, which challenge power hierarchies, which acknowledge strengths and engender this idea of agency and alliance. And we also developed this brief coaching model and video resources to support modelling and coaching, as I say, and development of a training guidance. Interestingly, this guidance on specific language, what we've actually ended up with in our training and in our handbooks for the practitioners are little bubbles at each stage of the intervention which says, you might say, and then some phrases of a way of saying something to a parent, which we've co-designed with parents, which don't alienate them, make them feel judged, etc. I was really worried about doing that with practitioners, with health visitors, with professionals. I thought this would be incredibly patronising, but actually it's really valued by the practitioners. They find it incredibly valuable. They know that they don't have to use those precise words, but they can use it as a basis for how they speak to people in order to challenge power hierarchies, etc. Okay. Enough. Now I can actually tell you about the intervention, what it looks like. So the intervention. So what we've created a set of resources, training resources, and hard copy resources and video resources for interventions, which you can have a look at in a bit. Let me just. Oops, sorry. And this is the model. I'll take you through what the model of the intervention is step by step, as briefly as I can. So, and hopefully you can check off in your head, have we ticked all the boxes of what we said we were going to do based on the based on our drivers and the underpinning theory. So these two steps of the ELIM-I process are about identifying whether or not a child has needs. So I won't go into that too much. But once you've identified whether or not a child needs additional support, you then move into this next phase, which is about the intervention. So you're deciding here whether or not you feel the child's additional support is needed or support is not needed. Even if support is not needed, as indicated by this process, we still give the family a talking together handbook, a leaflet. And this talking together handbook has information about why language is important, how to be a responsive caregiver. We call this being a super communicator. So this was something that parents co-designed with us as an idea that if you're going to be a super communicator, if your child has got difficulties, you can be a super communicator, which dials up these behaviours which is going to help your child progress. And so that's the phrase that they like. Within it, we've got 9 super communicator tips, and they've all got QR codes that take you to the Tiny Happy People website with 1.5 minute maximum clips, which show you how to do that super communicator behaviour with a child, model and demonstrate. And there's other additional resources there. So everybody receives that, whether or not you've identified the child as having difficulties. Once you've decided that a child does need support, you then move into a process of shared decision making. Now, first of all, you watch a video, which I can't show you because I can't come in and out of the slides very easily. But first of all, you watch a video with a parent about how to be a super communicator. And this shows 9 tips. And it shows the tips, first of all, you watch the video, the parents doing various things. And after each one, there's a piece of information that says, did you see the parent doing blah? And then you watch it again and you spot the different communicator tips. Then you enter into shared decision making, and this is actually a card sorting activity that the practitioner and the parent do together. They work through the 9 super communicator tips and they say, which ones are you already doing? You're doing lots of lovely things already. Which ones do you think you're doing well? Which ones do you think you might want to try to do a little bit more? They choose a tip that they want to do more of. So, for example, they might want to work on pausing and waiting more often. So they choose that as their super communicator goal. And then they work with the practitioner to find their best together time. So again, this is language that the families liked, is the idea of finding your best together time in your daily routine to practice your super communicator tip. So once you've done your shared decision making, you've set a goal with the family of what they're going to try to do more often, then you can move into either a kind of quite a self-directed approach or a coaching approach of support for the individual family. And the information that the practitioner is taking to help decide, they decide with the parent which feels most appropriate to the parent. Do they feel confident that they can give this a go, or do they want some extra support? But also we've developed some guidance based on the COM-B that we were talking about previously. Yeah, that's fine, that's perfect. Based on the COM-B, that the practitioners can reflect on, decide where the barriers are for that family. If the barriers are mainly about skills and knowledge, then you can provide a self-directed approach. And if the barriers are more around motivation, about feeling optimistic or not feeling overwhelmed by this approach. So if somebody has difficulties in this area or barriers in this area, then we recommend a coaching approach. And then if there are physical opportunities in terms of what's available to the child and the family physically or socially, then there's some additional support that we can provide them. So the practitioners using the COM-B to decide which of these to provide, and also whether or not there's some more signposting and advice that they could provide. There's this modified STAR coaching model that we've created to support practitioners to know how to coach at home, that we train people in. And they're given there's a super communicator booklet that the practitioner works through sequentially with the family, taking them through all of these stages of the intervention. I won't go through all of those. And all of them are linked to videos. And there's sections to support goal setting, reflection, and collaborative working at the back of the worksheet as well. Okay, I'd like to show you some more videos later, but I'll do that in a moment. Just to say, so for more detail, we've got these publications, and these are all the websites. And in conclusion, we believe that it's possible to develop intervention for use of the 2 to 2.5 year review to promote children's language development, and it's judged to be acceptable, feasible and equitable. We've developed all of these materials and training that support widespread implementation. We need to do more evaluation of the efficacy, and there needs to be some more work with families who speak languages other than English. But we are currently working with the Nuffield to evaluate remote delivery of this through telephone consultation with families, and we're hoping to get funding to evaluate its, fingers crossed, its efficacy very soon. Okay, that's enough from me. Thank you.